Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EUROTIMES. I'm Dr. David Granet. We're here at the Third World Congress of Paediatric Ophthalmology and Strabismus in Barcelona, Spain. Today, we'll be talking with Dr. Alex Levin, Chief of Paediatric Ophthalmology and Ocular Genetics at the Wills Eye Hospital. He's delivering the keynote lecture, during which he'll discuss how advances in ocular genetics are changing the way we care for our patients. Welcome, Dr. Levin.
Thank you for having me, David.
Alex, we're talking about a field that in medical school we heard about Mendelian genetics. It's exploded, it's changed, and now we're diagnosing and defining diseases differently than we used to. How is that changing the delivery of care and the practice of ophthalmology?
As if you'll excuse the quote, we live in exciting times. And things are changing so rapidly right now. What we learned in medical school is just a fraction of what we know today as modern genetics. And as a result of what we've learned, we're really in a time where diagnosing is different, what we call diseases is different, the number of diseases we've identified, the power that's now in our hands for potentially treating disorders which we used to think were condemning people to blindness has completely altered the landscape of what we're doing.
When you see children in your practice today, there are several kinds of diseases that may all look similar that we wouldn't be able to tell the difference before between those subsets. How do you deal with that now? What kind of orders are you putting on your sheets or in your EMR that you wouldn't have even considered or thought about in the past?
Well, I think the first thing is when we look at a patient's phenotype, what they actually have clinically, we think about it differently because we realize that the phenotype is a very critical part of the diagnosis that leads us to a genotype. That was something we never had in our formula before. The idea of coming up with a genotype, what gene is causing this disease, defines things in a totally different way. It defines it not only in giving it a name, and sometimes the name gets harder because one gene can cause multiple diseases, multiple phenotypes, and sometimes one phenotype can be caused by multiple genes. But it starts to open up opportunities in terms of counseling the family. What does this mean for recurrence risk? Is there clinical trials available? Is this an opportunity for treatment? What does this mean for the future of this patient and prognosis? And now, this patient is no longer somebody's name that we name the disorder after, but a mutation in a gene that gives us so much more information about what this patient actually has.
So is the ophthalmologist now the person who has to counsel the patient, or using genetic counselors? How are you getting that information back to the patient who, if doctors feel somewhat unequipped in this field, how do patients feel?
So you're touching on a very important point, which is that the information has exploded, the testing has exploded, the opportunities exploded, the moral and ethical duties of the physician have exploded, the counseling requirements have exploded. What are you going to do? And that's why we have this new field of ocular genetics. Unfortunately, there's only about 75 of us in the world right now who do ocular genetics. And with that comes the urgent need for genetic counselors to help us take the time to counsel families before testing, after testing, and in so many other ways. To be able to recognize these rare disorders, to be able to know what test to order, to know how to interpret the tests, and how to counsel the families. So a whole new specialty has arisen, and I think the general ophthalmologist, the pediatric ophthalmologist who's in the trenches, is now going to have to turn to the specialist for help because the amount of information has outstripped what any good, excellent pediatric ophthalmologist can know.
I'm thinking about the medical student pulling out his little computer trying to look up all this data and information. It is somewhat overwhelming to think about that. How does someone get trained? You're an ocular geneticist, but were there ocular genetics fellowships that you went through, or are we creating those now? Going forward, what are we going to do to make sure this information is in the hands of the people who need it?
So this is a question that's now on the table, is how are we going to do this? Who is an ocular geneticist? What is an ocular geneticist? So there are fellowships. We have a fellowship at Wills Eye Hospital. There are a few fellowships in the world for ocular genetics, but not many. Training programs specifically for ocular genetics counselors don't exist, and we're working on developing that now as well. But we need to have an educational pathway. When the medical students come into my clinic, it's a rare disease clinic, and they've read about these things in books. But actually getting a mastery of these diseases is going to take time and understanding and learning and fellowship training and experience. So that's a difficult challenge we have because we need more ocular geneticists to keep up with all the genetics information that's come, to the forefront these days.
For the practical people out there who are sitting and saying, it's great for the academic side of it, that's really neat that you have these names for it, you can identify the mutation, but can we treat patients? That's also exploded. We now actually can treat some patients. Where's that and where's the field going?
Well, with the very exciting work that's been done from several centers in treating Leber's congenital amaurosis, a blinding eye disorder, with one specific gene mutation, or one specific gene with several mutations called the RPE65 gene, we saw miraculously that these blind children could be converted into seeing children.
Miracle is the right word.
Amazing. Now, there are challenges. We're seeing that some of that effect may change over time, but nonetheless, it was a dramatic advancement. But what we need to do is, A, bring those trials to more diseases, and then bring those trials to the bedside. And that's a big challenge. There's many reasons, because of the regulatory processes that limit how fast we can go with this, the need for the financial underwriting of making these things happen. It's hard to get pharmaceutical companies interested in very rare disorders. Their agenda is different than what the clinical physician's agenda is and what the patient's agenda is. So we're in the process of seeing that transition and explosion happen. Many diseases are now coming into clinical trials: choroideremia, retinoschisis, retinitis pigmentosa, Usher syndrome, and others. So we're seeing in the next 10 years a wave of trials coming to the bedside, I hope.
Well, I can't wait to hear your keynote speech where you get to go into depth on many of these topics here at the World Society for Pediatric Ophthalmology and Strabismus meetings. And I thank you for joining us for just a few minutes, literally, before you give your keynote, and for all the great work that you're doing out there each and every day. Thank you.
Thank you, David. Thanks for having me.
Our pleasure. So thank you all for joining us out there. For more information on this and any of the related topics that you're going to hear on the Eye Contact videos, visit us on EUROTIMES.org. We'll see you again next time right here on Eye Contact. I'm Dr. David Granet.